I'm now going to introduce our fourth speaker, Dr. Bruce Crispin. Dr. Crispin is a world-renowned speaker on aesthetic restorative dentistry, from conservative treatment to reconstructions and implants. He founded the University of California at Los Angeles Center for Aesthetic Dentistry in 1987 and started one of the first aesthetic mini-residency programs in the country. Dr. Crispin received a DDS and a master's in prosthodontics from the University of Michigan School of Dentistry. He's one of the few people who have the unique combination of being a diplomat of the American Board of Prosthodontics and an accredited member of the American Academy of Cosmetic Dentistry. He's currently a professor emeritus at UCLA and alumni member of our OKU chapter here. Dr. Crispin has published over 45 research and professional manuscripts, including a textbook entitled Contemporary Aesthetic Dentistry Practice Fundamentals, which has been translated into 5 different languages. He has lectured extensively nationally and internationally over the last 40 years. It's truly a great pleasure to have Dr. Crispin back today to present to us. Please welcome Dr. Crispin.
Thank you. Am I live? Am I live? Hello, everybody. I think the last time I was on this stage was 40 years ago when I graduated, so it's indeed an honor to be back. I'm kind of the token restorative guy here to talk this afternoon, and I'm glad to see a lot of students here, so hopefully we'll show you a few tidbits. I can't remember the last time I gave a 40-minute lecture, though, so trying to figure out what I would say in 40 minutes. Usually I'm lecturing 2 or 3 days in a row, so my really objective today is just kind of to make you think a little bit and maybe shine some light on a few things, but I can't really get into anything in great deal, obviously. It was indeed an honor to follow such great scientists. I have done some scientific research, but probably more in the restorative vein. But, you know, I was looking at the stage here, and they're having a group discussion afterwards, and there's been 4 speakers, but you'll notice there's only 3 chairs. So I think maybe they're trying to tell me something. I don't know. I thought just to start out at the very beginning, I'm going to bore you just for a couple of minutes to kind of share with you my 40-year journey. And this is my 40th anniversary from dental school. And so I've already seen a couple of classmates in the audience. And so we're anxious, I think, to get out of here and start celebrating. But anyway, my 40-year journey actually started here at the University of Michigan, as I mentioned on this stage. And over that 40-year period, I got my degree in 1972. I was an instructor for 1 year. And then I went through Dr. Joe Clayton's program, who really provided me, I think, the foundation for many of the things I still do in restorative dentistry. I went to the University of Liverpool after graduation. Dr. George Myers, which has been long gone from the university, was from England. That was my year in kind of calming down after graduate school and getting my beer consumption up about 400%. And then after that, I was hired at UCLA. I was the only mail-order professor that was ever hired there. I was hired with my 1-page CV. And I taught at UCLA for 1976 through 99, and I started the first aesthetic center in an academic institution in the United States. And right from the very beginning, most prosthodontists really got into implants. And in fact, I bought the first implant system for UCLA when I was dean there, dean of the clinics. But anyway, I kind of really liked restorative, and I liked aesthetic restorative dentistry. And my thought was that aesthetic restorative dentistry really is the future of dentistry. Now, when I'm thinking back in the late 70s, you know, when I introduced all ceramic crowns to UCLA, I was considered a heretic. They said, oh, these will never work. And then we got into veneers and all the other things now that we take for granted. So we're going to share a few of those things with you. After putting up with the politics at UCLA for 23 years, I decided that I'd had enough. And so I started my own private postgraduate school called Aesthetic Professionals. This is in Tarzana, California. So now I have a 16,000 square foot building, and we can pretty much teach whatever we want, whenever we want to. And if I want to learn something, I put on a class, so I learn how to do it. So anyway, so I would personally like to take just a minute to take an opportunity to thank the University of Michigan for really giving me the foundation and the opportunity to do the things that I've done in life. And I've pretty much done everything I wanted to do. And I think the university has really provided me that foundation to allow me to do that. Obviously, it took a little hard work along the way. Now, you may be asking, where's Tarzana, California? So I threw this little map in here. And if this is actually Los Angeles. This pointer's not very good, but I guess you can kind of see Los Angeles. Santa Monica, I've got the LAX there. Tarzana is actually about 20 miles or so from LAX and kind of just into the San Fernando Valley. And the reason they call it Tarzana, it was the home of Edgar Rice Burroughs, who was the author of Tarzan. He had an estate there. So a little history. Okay, back to my topic. My topic is congenital tooth defects, and I've kind of deviated a little bit from the topic. The primary topic was enamel and dentin defects. I'm going to show a few cases on congenitally missing teeth, just to kind of give you an idea of some of the things that I teach and some of the things that I do. So I'm going to talk a little about clinical treatment, and these are the three areas that I'm going to be talking about: missing teeth, isolated tooth defects, and then we'll get into complex restorative dentistry with a more complicated case. So a little bit on congenitally missing teeth. My treatment objective, as I mentioned from the very beginning, is to try to do the least invasive procedure possible. I will tell you, I've screwed up thousands of teeth as a fixed prosthodontics, ground away to little stubs. My objective has always been to do the least invasive thing possible. So I'm going to try to show you some techniques that I've developed over the years or have copied over the years in some instances, so I can be minimally invasive. And especially if we're talking about younger populations, we certainly want to be as minimally invasive as possible. Now, you may recognize this prosthesis. It's a Maryland bridge, and I don't know if they still teach these. I know there's a lot of students out there, so I think there is anyway. So if they're still here. But anyway, it's just an adhesive bridge with tabs. It was very minimally invasive, minimal amount of tooth destruction. And I think that over the years, it's like, these things don't really work. You know, they're really not going to solve long-term problems, and people overtreated, and it had a lot of failures. But this is a Maryland Bridge case that I did. I did it in '87, and this photo was taken in 2012. And you may say, oh, it's not the most beautiful case in the world. But I didn't have to destroy this individual's teeth. They're still there, and it's still functioning strong, and I can show you a number of these cases. But I think what it really did for me, and I did some research at UCLA and followed these cases for many, many years in the '80s, but what it really did for me was provided a genesis of thought. And the genesis of thought for me was, if I can stick things to teeth, if I can replace teeth, if I can cover teeth, I can modify teeth without having to grind them down to little bitty stubs, I think I'm doing that patient a significant advantage. When I first started doing these Maryland bridges back in the early '80s, I would tell my patients, I don't know how long they're going to last. But let me tell you the good news. The good news is, what's the worst that can happen to this? It falls out. And what happens with it falls out? You still got most of your tooth left. And think about what's going to happen in that 5 years that it'll last, or 6 years, or 8 years, or 10 years, or in this case, a lot longer than that. This patient still has, 90% of their tooth structure. And if you think about the adhesive materials and the ceramics and the things that have been developed over that period of time, it's amazing. Now this patient can take advantage of those things as opposed to grinding them down to little stubs and have the long-term consequences of that. And it's not just dental, it can be periodontal. So anyway, that's where it kind of created my genesis of thought to search for ways to solve problems and be minimally invasive. This was a young lady that the orthodontist, you can see nicely, put her canines in the lateral position. I love when they do that. That's probably malpractice by today's standards in orthodontics, at least it would be in my opinion. But she's got a congenitally retained deciduous tooth that was going to be lost. So what are we going to do in a situation like this? What are our treatment options? We can extract it and do an implant. Great option. Or we can do a fixed partial denture. Now, I think most of us would say, well, geez, let's do the implant because obviously we got two nice teeth there and we don't really want to screw those two nice teeth up, so let's go put an implant in. Well, what if there's not enough room? What if the patient can't afford an implant? Are there some conservative ways to put a fixed partial denture in this situation and restore this tooth? And that's what I actually did here. I did a minimally invasive fixed partial denture. The canine, which is really in the lateral position, just did a simple bonded metal lingual retainer, kind of like a Maryland bridge retainer, but just one unit. Put a little dimple in it, so it had a little finger rest. Patient already had an MOD amalgam, so I essentially just removed the amalgam. Got a little taper on it, so I had to do a little bit of tooth destruction. Then we went ahead and made a provisional. And then we went ahead and extracted the tooth, created our ovate ponic site. And so you can see the amount of tooth destruction on the canine in the lateral position was probably a few tenths of a millimeter, didn't even get through the enamel. The bicuspid, I went and just took a little more tooth structure away to get a line of draw, and that was the extent of my destruction for this fixed partial denture. And then we went ahead and placed a prosthesis. This is the metal substructure, and you can design these in a lot of different ways, and we don't have time to get into the alternative, but this is an older case. I'm trying to show you a case that have been for a long period of time. Made a metal substructure, opaqued it, and created, and this happens to be composite, indirect composite over metal with a little finger rest. So we got an inlay. That's not a crown, that's an inlay, a ponic, a little finger rest, a little small bonded retainer, and you can see the aesthetic results. And this patient happened to be one of my dental students, so she was probably in her, I'm guessing, in her middle 20s at the time. So a conservative way to do a fixed partial denture. So here you can see her smile. I also went in and did some bonding on the lateral incisors just to make them look a little more like lateral incisors. And here you can see the result. Okay, so what about this case? Here's a Maryland bridge case that I didn't do. And it was a 17-year-old girl that was off to college. You can see she's got defects in the bone, would have needed bone augmentation. She would have had to have possibly, if we were going to do implants. She had Maryland bridges. The problems were that she didn't like these, obviously. She was graduating high school. She was about 17, 18 years old. She had diastemas. And she wanted to have her teeth fixed, and she wanted to have them fixed like right now. She didn't want to go through the process of augmentation implants, which certainly would have been a great treatment. I'm not condemning that at all, but she was going off to college, and I said, okay, well, I can do these kind of conservative bridges. They were going to look really good. I have no idea how long they're going to last. So we went ahead and made some substructures. Okay, these substructures were actually metal reinforced. You can do them with pressed ceramic or metal. There's a bunch of ways you can do them now, but this was a little older case. It was actually indirect composite over metal to give us some rigidity, and then we actually prepared all 4 teeth, including the ponics, for veneers. Okay, so we duplicate the model, make the veneers, make 4 veneers, and the end result, you can see the substructure in the veneer, this is kind of a hybrid bridge, and this is the final result. Very predictable aesthetics. Very conservative compared to, let's say, full coverage fixed partial dentures, which I wouldn't want to do. But in this case, and this is what it looked like 14 years later. So can these conservative alternatives last? Well, I think they can. Again, what's the worst that could happen? It falls out, and you can go to something more destructive if you have to, or maybe the patient's in a better position to afford the implants or a different type of dentistry. You can see the only thing that really happened, interesting, you lose bone when you lose teeth. Well, God, 14 years, that ponic is still touching the tissues. Some of them may be hyperplastic, some of them from irritation. She did get a little recession, but it's still there functioning and still working. Now, we certainly also have the implant option when you're congenitally missing teeth. So here we've got a case where we're going to put an implant. We've got a lateral incisor in the 10 position that's too small. It doesn't fill the space. So we went ahead and placed an implant in the number 7 position. This is actually the provisional. And so, again, I don't have time to really get into all this stuff, but placing the implant in the right spot, that's where it starts, and making sure that you have good communication with your surgeon. And it's not that complicated. But then you have to make a good provisional, and the provisional phase is fairly important to make sure that those tissues are formed and you can optimize your aesthetics. And then in this particular case, I designed a little bit different type of custom abutment. And the abutment is what hooks essentially the prep that goes over the implant. And you can see this is not a zirconium abutment. This actually is a UCLA abutment. So we cast a metal substructure, and then I went ahead and put opaque and built ceramic over it. So it's a porcelain fused to metal custom abutment. Now, why would I do that? Well, it's not that easy to bond to zirconium, although we're getting better at it. We have some shades, and when I did this case, they didn't have the full shade options that we do with zirconium, but now I've got a custom abutment that has conventional ceramic that I can etch. I can etch my conventional ceramic or whatever kind of ceramic crown I'm doing, as opposed to this would be either Emax, or I like to use conventional ceramic because it's a little more aesthetic for these onesies. I can bond all this together, and I've got total aesthetic control because I can make this out of any porcelain color that I want to. And here you can see the crown over the abutment. Here you can see the custom abutment now. We designed the custom abutment to have a dentin shade similar to the adjacent teeth. You can see the prepared veneer on the number 10 position, and you can see our final result. And it's all about getting good translucency, getting good tissue health, and making it believable. And you can do it in very conservative and creative ways. And here you can see the final smile. In this particular case, this young lady had a fairly high lip line, so obviously getting a good total end result was important. Okay, enough on missing teeth. Let's talk a little bit about isolated tooth defects. I'm probably in a better position to understand what to call these things, although I'm a little bit confused because I have so many options now. It's like I'm going to have to, you are going to send me a copy of this lecture, right? So I can review all these options. But this was a young woman, probably in her early 40s, maybe late 30s. They came in, and you can see all the little model defects. So I'm sure you guys can tell me exactly what this is, or at least get a good indication. And she's got some little defects of varying degrees. You can see some chipping. And again, her goal really was, she just didn't like the way it looked. She wanted to look better. And we want to do something that's predictably aesthetic, enhances the function, and is going to have some longevity. Well, anytime you see canines that are chipped and worn, obviously, and you start diminishing canine guidance, you very potentially going to be affecting the function. So for years, I've treated cases like this. My mouth actually is treated exactly like this, and my son's mouth is treated exactly like this. So in this particular case, the first thing we did is want to bleach her teeth. Never miss that, what I call the window of opportunity. You're going to be doing some dentistry that's not cheap necessarily. Even if it's just direct bonding, it's not cheap. And so, always ask your patients, do you like the color of your teeth? Or maybe we should consider bleaching them if you'd like to brighten them, because once I put my restorative materials in there, the color is going to be somewhat stable, at least for those restorative materials. So we bleached your teeth first. I bonded the cusp tips on the canines to restore canine guidance. Okay, this was a functional improvement as well as a somewhat aesthetic improvement. And then we contoured her lower teeth to get rid of the fractures, and that there was just a simple enamelplasty, and did veneers on teeth 7 through 10. And this is the final result. Now the question I usually get asked is, well, geez, if I just stick a little composite, which is what I did here, on tops of those canines, isn't that just going to fall out? I will tell you, I do these all the time. And I think it's malpractice, personally, not to do that. You see a patient come in your practice, and you see a worn canine, okay? Start looking at the bicuspid. Oh, yeah, there's a little bit of wear on that bicuspid, and you can see it kind of gets progressively worse oftentimes. Well, let's just watch that and see what happens. That's not what you do. It was like was talked about a little bit earlier. We want to discover these problems as early as possible, and we want to treat the problems as minimally invasive as possible and try not to make them worse. And one of the best services you can do is go in and take those worn canines, bond some cusp tips on them, restore that anterior guidance, and minimize the potential to have those lateral contacts on those posterior teeth, which lead to wear, fractures, and all kinds, and breakdown of our restorations. And does it work? I will tell you, absolutely it does. Now, if the patient breaks it off in a few weeks, what does that tell you? Well, either they're using their teeth for tools, or maybe they've got another problem that you got to deal with, but then you're going to go maybe to another step of treatment. And I will tell you, the majority of these don't fracture. Here you can see the pre-ops, post-op right, post-op left. And the goal, again, is to make everything kind of blend in. So we got natural teeth that we brightened a little bit with our bleaching. We did some bonding, and composites today are totally invisible if you do any bonding at all. You just don't see them. And then we've got our ceramic veneers, and it all just kind of blends in somewhat seamlessly. Very little tooth destruction, very little tooth modification. And so I don't have time to go into my 3-day lecture on veneers, but I thought I'd bring out just a couple of little points when it comes to ceramic veneers. And that's really understanding, first of all, how much enamel you have to work with. Now, if it's a defective enamel or non-existent enamel, then obviously it might be another treatment. But this is an unpublished research project I did at UCLA, and what I found was, if we sectioned hundreds and hundreds of teeth, extracted teeth, we found that if you're looking at about 1/2 millimeter from the CEJ, you can see the enamel thickness averages less than 3/10 of a millimeter. And if you go in about the middle of the tooth, we've got a fair amount of enamel to play with. And what's our goal, obviously, when we're doing any kind of bonding or veneers? We want to maintain enamel if possible, because if we can maintain enamel, we're going to have longevity. Why do you think lumineers work? Because they don't grind on the teeth. They stick them to enamel, and they last forever. They may not look so hot in some instances, but they stay on because you're bonding to enamel. And then if we look in the incisal, and I'm going all the way. This screen is awful. You can't see a thing over there, I'm sure. I can hardly see it on stage here. But anyway, you can see the amount of enamel is significant. And so if you're dealing with discolored teeth or tetracycline cases or whatever, and you need more room, just don't dogmatically go in and take off 3 or 5 or whatever tenths of a millimeter. You need to control the depth based upon what you're trying to accomplish. Whether you're building the tooth out or whether you're not building the tooth out, you have to be able to control depth. And be able to control depth, you have to have instrumentation. This is my favorite little kit. It's from a little company in Chatsworth, California. And this little kit allows me to make depth cuts in the enamel from 0.2 to a millimeter. And so based upon what I'm trying to do, I can do the minimal amount of damage possible. And I can control it, because when it comes to preparations, and for those of you that are dental students, it's all about maintaining points of reference. And as soon as you lose your points of reference, your teeth, you run into the real probability that you're going to under-reduce, over-reduce, or maybe not reduce with symmetry. Here you can see a tooth, and you can see how this is a nice, safe instrumentation. And in my textbook, I make a couple of depth grooves based upon what I want to accomplish, what's my end goal. And then I can go and simply reduce that facial surface and use those depth grooves as my point of reference for the amount of reduction that I want. Other ways you can do it, you can take a diagnostic wax up, which you can see on the top here. You can make little putty stents, and then you can do your preparations. And then you can take the stent, and you can see, does that tooth fit in to my stent? Is it symmetrical? Is it giving me the amount of room that I want for whatever procedure, in this case veneers, doing? So it's all about points of reference when it comes to being conservative. If you don't have good points of reference, you end up with teeth that stick out, or maybe you end up with thick and thin areas, and especially with veneers where you're covering discolored teeth, if you have thick and thin areas, you're going to have differences in color, and that's very difficult to manage. Another thing to do, especially when you got malpositioned teeth, rotated teeth, teeth that are buccal version, lingual version, is just simply do a mock-up. You take your diagnostic wax up, you make a little putty stent, or some type of stent, you fill it full of a provisional material, and you just stick it on the teeth. Okay, so now you got malpositioned teeth. You essentially take them to your proposed contour before you even start, and then you prep through this mock-up the depth that you need to have for your final result. And then you can see in this particular case, this individual had teeth that were in lingual version, and you can see by the shiny spots on the enamel that I didn't even get into the enamel, which is great because I got a lot of enamel left to bond my restorations to. And had I not had a way to evaluate points of reference, I probably would have gone in and made my depth grooves and made it way deeper than I really had to. And here you can see this particular case. We bleached his lower teeth. He was a man probably in his mid to late 60s, early 70s maybe, just kind of normal wear for someone that age, I think. I'm not sure what normal is anymore, really. But we went ahead and restored his upper teeth. We were very conservative, placing margins right along the tissues. Because when we did our evaluation, it wasn't necessary to go below the tissues. And this is actually our first recall, and you'll notice I actually have a little cement. These cements are so translucent it's hard to see, so in our first recall, we evaluate tissue response, and did we really clean it up, and occlusion and all those types of things, and do we need to do some contouring? And you can see he has a fairly low lip line, so in reality, we didn't really have to go subgingival and get onto non-enamel surfaces. Now, what about materials for these types of restorations? And I think that, oftentimes it's the material du jour that we want to use. Certainly, Ivoclar has spent massive amounts of money promoting Emax. And I will tell you, Emax is a great material. I never really got involved with Emax. I've done pressables for many, many years, all different types, because I own a laboratory and I have too many materials. But I never really got involved really with Emax for one simple reason. Initially, it just didn't have the translucency range. Aesthetics is all about translucency. It isn't about grinding on teeth. It isn't about, a good laboratory. Well, it is about a good laboratory to a certain degree. But the ultimate aesthetic product really is all about understanding translucency and controlling translucency, especially if you're matching adjacent teeth. Now, if you're just making a bunch of restorations that are matching restorations, it may be a little less significant. And a few years ago, Emax finally came out with a broader range of translucencies, from fairly translucent, which we use for inlays and onlays especially, to a certain degree veneers, because remember, enamel is fairly translucent, to fairly opaque. And so we've got that range of materials now to deal with. And so if I'm doing multiple units, I like to use a pressable material. And certainly Emax, because of its strength, I think is a very desirable material. I think the downside of a pressable, and let's say Emax, because that's certainly probably the most popular one right now, is that if you think about it, what is most of your restoration made out of? It's made out of the pressed material. Okay, Emax is a pressable. You press, if you're pressing your veneer, most of that veneer is the pressable. And then they'll cut it back a little bit maybe and put some enamel on it. Or they'll just stain it, depending on, I guess, how much you want to pay for your lab cases and what circumstance and where it is and so forth. So 70% or so of the restoration is going to be your pressable. And if you're doing a bunch of restorations, fantastic. Because restorations are going to match restorations. It's stronger, probably more predictable, harder to break. If you've done many veneers, you can break them if you get a little bit too cavalier. In contrast, if you're doing a onesie-twosie, and you got to match adjacent teeth, especially ones that have a lot of characterizations and color, there you need to have more space and more room and more ability to build in all the different layers and incisal translucency and so forth. And so that's where I tend to still favor conventional ceramic. Now you got to remember, front teeth are going to have the least amount of stress put on them. Certainly I don't use conventional ceramic veneers or crowns for posterior teeth. You could probably get away with bicuspid maybe, but usually as you go further back in the mouth, aesthetics become less demanding. Singles, onesie-twosies in the front, more demanding, and that's where I like to use conventional ceramic in many instances. It just gives me more flexibility to match whatever I'm trying to match. But press ceramics certainly are great. Now, what do you do when you're dealing with a situation like this? As I mentioned, it's all about translucency. So here we got a situation where we've got a discolored lateral incisor. This patient was referred to me because the dentist had already made him 2 veneers, and it didn't match. And why didn't it match? It didn't match because the tooth was discolored, and they had tried to accomplish the task of matching those other teeth, and you can see there's lots of colors in these adjacent teeth. They tried to do it by opacifying the veneer. And you'd think, that seems like a logical approach. You got a discolored tooth, opacify veneer, cover it up, live happily ever after. And I will tell you, that's not the way to do it. The way to do it is to opacify the tooth. So, do we opacify the veneer? Do we do a crown? Make more room, grind it down to a little stub? Just, give me a crown, I got lots of room to do whatever I want to. Do we opaque at the preparation appointment? In other words, do I opaque that out, cover it up with some kind of bonding material to get rid of some of that brown at the preparation appointment? Or do I do it at the delivery appointment? These are kind of at least some of our options. And I will tell you, I think the solution is to control opacity by making your veneer to match the adjacent teeth whatever your ceramist has to do, and disregard the color of the prep. And then you're going to go ahead at the delivery appointment, you're going to try in the restoration, and you're going to see, does this ceramic restoration, does it solve the problem by itself? Because if you over-opaque it, you're done. You can't get rid of too much opacity when you got a veneer. You're done. Your appointment just ended, so did your profit, maybe your credibility. And that's probably why I've referred this case, because the dentist did that a couple of times. In contrast, maintain the correct translucency and color that you want. Try it in. See if you've got a problem. And if you've got a problem, go ahead and what I call sub-opaquing the preparation at the delivery appointment. Now, why do I like to do it at the delivery appointment? Well, the reason I like to do it at the delivery appointment, I want all my bonding to be done simultaneously. If I go ahead and try to bond this at the prep appointment, that bond, all that resin is going to be somewhat contaminated over that week or two before I get the restoration made. Plus, I got to get a temporary to stick on that veneer, and I'm going to stick it to my bonding, and if I stick it to my bonding, am I going to really be able to get it off? You know, it's just too many problems. In contrast, when I'm putting my bonding agents, my opacers, putting them all on at the delivery appointment, everything's fresh, everything's done at the delivery appointment. So now I try this thing in, and I look at it and say, yep, sure enough, I'm still getting some color. Yeah, it's not so bad up here, a little bit low in value, but I'm still getting some color coming through gingivally. And so I put my bonding agents on. Actually, I usually take a little round burr for a point of reference and create a little space. I don't have time to go through the whole technique, but I go ahead and sub-opaque this, put a little opaquer on like I showed you in the last image, and try it in again. And I can dial it in at my delivery appointment. Okay, I also assume that I'm going to spend more chair time, so I charge more for this, because it's going to take me more chair time to dial this in. So if you want to be profitable, you got to predict the problems before they happen. So we went ahead, not enough opaque here, went ahead, opaked it a little more, and there's what it looked like. Not perfect, but pretty darn close. At least we got this patient happy, and you can see the number 7 is a little lower in value. We tried to make it somewhat bilaterally symmetrical. You can control everything chair side. Success is being able to close cases chair side. Making a profit is closing cases chair side. Not continually sending it back to the lab, because as soon as you send it back to the lab once, your profit's gone. Not to mention your credibility, as in this case. Question, how old do you have to be to have definitive treatment? This was a 17-year-old post-ortho case. Is this enamel deficiency? This is probably not genetic, although maybe a little bit. It's certainly genetic for the tooth size. But here we've got a young boy, 17 years old, had ortho, and you can see his teeth just aren't big enough to fit his arch. So what do we do here? It's got little short teeth, all the wrong size. Are we going to do some bonding on here, some temporary bonding, or some bonding for a few years and getting them through? And okay, well then we'll go back later and do more definitive treatments. Early when I got out of school, that was what you had to do. I don't think that's necessarily the case with conservative restorative dentistry. In this particular case, I sent him to, well, we obviously went through a bunch of diagnostic procedures to determine exactly how long we wanted to make these teeth. But he had altered passive eruption. We needed to accelerate the eruption to the point where it would be more normal for somebody a little bit older, maybe. So we went in here, laid a flap, and we went ahead and raised the bone. And there's very precise ways to predict exactly the outcomes in these situations. So we laid a flap, did a little osseous, waited for 2 or 3 months, probably 3 months for everything to calm down. This is just post-surgical. This was before. This was after the surgery. And this was before, and this was after we did our restorative procedure. Very conservative, minimally invasive veneers. Beauty in this case, it's almost all additive. I put little margins on, maybe a little bit of shaping, but for the most part, it was an additive procedure. And you say, well, geez, how long is that going to last? Well, this was 7 years post-op, and you can see it's still pretty stable, pretty darn healthy. Because I didn't have to go in and make things super gingival. I didn't have to be invasive. We did the surgery in a very predictable way, and you can do that. And then finally, let's talk a little bit about a more complex case. How am I doing on my time? How much time do I have left? 5 minutes? Huh. Oh, really? Oh, I'm going too fast here. Well, I've never given this lecture before, so I'm not sure you're not going to argue or worry if I get done a little bit early. Anyway, here we've got a young woman that came to me, and she had had, obviously, different types of restorative procedures over her short lifespan. She was, I would guess this woman is probably in her late 30s, middle to late 30s. Didn't really look up her age, but that would be my guess. You can see some significant enamel defects here. And she'd had, bonding done. She'd had some stainless steel crowns done. She had gingival recession. Some of it may have been iatrogenic. I don't know, maybe not. Hard to say. Here's her panoramic X-ray. So you can see the stainless steel crowns in the back. You can see the lost tooth structure in the front and various, direct bonding procedures, with some are fairly opaque, some aren't. Now, when you're going to be treating more comprehensive cases, I think the number was $20,000 for 24 teeth. I don't know about Michigan, but that's a pretty conservative number. These things can get quite expensive. And I think that I will tell you, one of the big things you have to learn when you're doing comprehensive dentistry is how to organize it. You can do it all at once. And if your patients can afford to do it all at once, this woman could, but if your patients can afford to do it all at once, that's great. But what if they can't? What if they can't? Do you not treat these kinds of patients? And I will tell you, almost every reconstruction case, you can treat and you can segment, but it's all about organizing your cases. I will tell you, I can teach a third-year dental student how to do this case. And because I've done that. It's all about breaking it into what I call the baby steps. Okay, try to simplify the case, okay, and try to organize it so you can, in some instances, segment it. Now, there's lots of ways to do that. This maybe is not the greatest example because I didn't really segment this case, but I'll tell you a little bit about how I went through some of the steps. First thing, obviously, that you have to do before any case is diagnosis. It's all about diagnosis. I tell you, grinding teeth is not that difficult. Joe Clayton used to say, I could teach a monkey how to grind teeth. I always think about that, and I'm not sure that's exactly true, because I've had a lot of students that weren't that great at grinding teeth, but I mean, that's not the hard part about these restorative procedures. The hardest part about complex cases, really, is what you do before you start the case. And that's really what I gleaned from my graduate program. Organizing the cases before you start, diagnosing the problems. And the problems may be that patient, what they can afford, how fast can you do it, what circumstances do you have to deal with, and then come up with a reasonable solution to solve the problem. And it can be done. It can be done. Now, you're not going to break a full mouth reconstruction most likely down into one tooth at a time, although you possibly could. But that might be a little extreme, and you'd have a lot of different colors maybe when you're done. That'd be kind of cool if all the different crowns made over periods of time. But you need to have some good instrumentation. This happens to be the Cavo. I probably have 200 articulators of all different kinds. This happens to be a little older generation of the Cavo. But it all starts with diagnosis, getting a good face bow. I know as dental students you think, man, they showed me how to do that face bow. I have no idea really why they did that. We did it once. And I'll tell you, every student that comes to my office brings in their articulator. They're all set exactly the same. And they never change the settings on them since dental school. And they can't remember how to take the face bow because the last one they took was in dental school. And somewhere there's a breakdown. Somewhere there's a breakdown. Maybe it's just because they're not doing enough complex cases. Well, a denture is a fairly complex case. I mean, a denture, you got to get symmetrical. A denture, you got to get the midline too, And so it all starts with diagnosis, taking a face bow, and it's all about really getting symmetry, getting midlines. Because by today's standards, if you got cants and caca teeth, you're going to fail. And then you need a good instrument so you can send back. You don't send your instrument back and forth to the laboratory anymore. You get an instrument that has magnetic mounting plates, and you never send your instrument back to the laboratory. Like I said, I got lots of articulators, and I used to send them back and forth because they weren't very accurate. Not so true anymore. You got Cavo, and even Denara finally came out with a decent new articulator, and Artex, and SAM, and there's so many good instruments out there you need to get in a newer generation. And then you need to do your prototype. Your first prototype is your destination. Where are we going with this case? And patients say, Doc, I don't think I can afford it. Or they say, how much is it going to cost to do this? And I say, I don't know. But let me tell you how much it's going to cost to find out. And that's the diagnostic phase. models, x-rays, pictures. And if you don't like me, you know, if I piss you off, you can take them with you. But somebody's got to do it. And with complex cases, if you're going to get acceptance for complex cases, you have to establish relationships with your patients. And you're not going to establish relationships with your patients in a 5-minute quick hello, how are you? It's going to cost you $40,000. Please take it. I'll see you later. It doesn't happen. It's a process. Now, I'm fortunate enough to get referrals by dentists, not all of them, but some of them. And so I kind of have a pre-established credibility, but most practices aren't like that. And so you have to create relationships with your patients. It's all about having some time. You know, so you get the patient in, you take some impressions, and you take some x-rays. Did they show up on time? Do they complain about the fees for that? If they complain about the fees for that, how are they going to afford a reconstruction? They probably can in many instances, but at least you know that that could be a problem that you'd have to deal with. Okay, then you get some models and you create a prototype, and you have to go through an aesthetic and diagnostic process to figure what are their problems. Midlines, lines of planes of occlusion, occlusal vertical dimension, which has been mentioned many times here. Okay, you have to diagnose that. So you make a prototype. And don't make a prototype or a diagnostic wax up with green wax or blue wax. I mean, imagine if you were not a dentist and some doctor comes in and said, I'm going to charge you $40,000 and this is what I'm going to do. And they show you this model with a bunch of green teeth. Wow, that's going to really sell that case for you. So make it look presentable. You're trying to create a relationship. You're trying to let that patient know that you're the best thing that they've ever had. You know, and if they don't come back to you, they're crazy because you're comprehensive, you do the right things, and you're doing things that no other dentist has ever done in many instances. And so we made our prototype. I like to have I own a laboratory, dental laboratory, so I have my laboratory, put a little pink on it so when I'm presenting the case. Now, obviously, these aren't mounted. I basically just took it off. The case is done. I already took the models off, so I just took pictures, but these would have been mounted on an articulator. And at my appointment, I'm sitting down and talking to my patients, well, this is what we can do. Now, patients, I don't think, can really diagnose from diagnostic waxes, but what they can see is the scope of change. They can see the scope of change that you're making. And you're creating a destination. I'm not going to talk about money here, but let's figure out where you want to be when we're all done with your treatment, assuming we do treatment. Whether we do it in 6 weeks, 6 months, or 6 years, how are you going to get to a desirable, optimal destination or end product if you don't know what that is? It's just that simple. So you have to determine that first. And once you figure that out, then you can figure out how to get there. Then we go ahead and duplicate the models. We make little vacuum form stents. They can be used for mock-ups. They can be used for provisionals. And then we go through our sequence of treatment. In this particular case, she wanted it done in a fairly efficient way, so we prepared all her maxillary teeth. We prepared her lower anterior teeth. This appointment I'm going to spend a little bit of time on because there's, you can see a whole bunch of stuff there. We did our first ceramic try-on, and we delivered it. It took me 5 appointments. Could it take longer than that? Absolutely. Could I spread it out over a long period of time? Absolutely. And you can do that with some creative diagnosis and treatment planning or sequence planning. Now, the first thing I did is I prepped 5 to 11. Why did I prep 5 to 11? Because I almost never prepare an entire arch. Why? Because it's too darn hard. If you can prep 6 teeth, you can do a full mouth reconstruction. So for you dental students that haven't maybe prepped 6 teeth yet, that's got to be your goal. If you can prepare 6 teeth and make a provisional, you can do a full mouth reconstruction. Now, why did I go 5 to 11? In this particular case is because the restorative materials that I'm using. I'm going to do Emax on her 5 to 11. On the molars, I'm doing ceramo metal. Why am I doing ceramo metal on the back teeth? I think they're more predictable. Now, is Emax maybe strong enough? Maybe. But ceramo metal's been around forever. Then I went ahead and prepped the molars. So basically, I prepped it kind of in 3 segments. Prepped the anterior teeth, made a provisional at the right vertical dimension, whatever that is. Maybe I was changing it, maybe not. Established my anterior aesthetics. I always want more time for that first appointment. You want to be the hero out of the gate, I call it. When they walk out the door, your patient should never, ever walk out the door looking worse than they come in. And if they do, you're just not doing it right. Once you're the hero, once you make them look better after the first appointment, you got them. You start eliminating a lot of those, what I call psychology of success issues. If they look worse, then they start to distrust you and get, doesn't necessarily make a very compliant patient. All right, so all ceramic 5 to 11, ceramic metal. And then we made provisionals. I made impressions. And this is what I came up with. I had 3 different models. And then I made substructures. Well, I can't make substructures for Emacs because there's no substructure. But I could make metal substructures on the metal, and that's why they're blue, because we don't need to have translucent restorations. Went ahead and made a provisional. I do not make indirect provisionals. I make them all chairside. And with a little bit of resin tint in between the teeth, you can actually make them look halfway decent. Get a nice diamond disc and a little tint, and you can actually make them look a little more individualized. Notice that I didn't prepare this area. Why? Do I want to make a big, long, honking crown just to fill up that space? Is that the appropriate treatment, or is the appropriate treatment a gingival graft? When I got out of dental school, you had to make long crowns. That's not the correct treatment by today's standards. Today's standard is to do a gingival graft. Well, it wasn't quite, did I want to do a gingival graft, or did she want me to do a gingival graft and wait for 2 or 3 months for that to heal? Didn't want to do that. Okay, so we prepared the tooth, speculating on getting the gingival graft after we restored the case. Plus, with the new restoration, it's going to be in a better position to heal anyway. Then we hadn't prepared the lower anterior teeth. Why did I do that? All the same material again. And then I went ahead and prepared her lower molars at the 3rd appointment. Now, here's a complicated appointment. We have metal substructures for the back. In the front, I just made acrylic substructures, not a GC pattern resin or something. I just needed something that I could use, one, to put in the mouth, check my die accuracy. Because now I got all these different models, and I've got to get them all on 2 models so I could fabricate the case. Okay, so I think you can start to get a feel. You don't have to do this all at once. You can actually do it in these segments if you want to, and finish that segment before you go to the next segment. You got me? Okay, so anyway, here's our anterior segment. We did acrylic substructures, metal substructures in the back, made our lower provisionals. Notice that I didn't go to the gingival level here either, because look at the gingival morphology. And it really wasn't a very aesthetic area anyway, so why go down and irritate the tissues if you don't have to? It's easier to make impressions if nothing else. Then, once we got our provisionals in this particular case, we took some photographs. Never, ever evaluate aesthetics for things like this with a mirror. What's the problem? Patient's looking in a mirror, you're looking at them direct. You're looking at 2 different images. They're looking at indirect, you're looking at direct. It's a flip-flop. When you're evaluating, you take photographs. And you sit there with your patient. You can do computer imaging, and you can draw lines, and you can do whatever you want, print it out, whatever technology you have. And then we're going to take this along with an impression of our provisionals and send it to the laboratory. And the potential to have errors and cants and midlines and so forth is virtually eliminated. That doesn't mean your provisional is perfect, but you've got a point of reference. A photographic point of reference and a model of this that you can send to your laboratory. So now we can check all this and see how you like it. And the patient can give you feedback and tell you what they like and don't like. And then we make a fairly sophisticated model system, which I don't have time to get into either, but you can see we try to maintain our soft tissue morphology as much as possible. There's the uppers and lowers. Went ahead and did our first ceramic addition. So we got pressed ceramic in the front, ceramic in the middle and the back. Now, when I was in graduate school, we were taught to remount, which means you get your case done, you remount it, and then you sit in the lab and you grind the occlusion in. I have not remounted since I left graduate school. And it's absolutely unnecessary. You do that by fabricating the upper arch to full contour, full morphology. You do the anterior teeth, the full contour, full morphology, full occlusion, anterior guidance, vertical dimension. Posterior molars are totally out of occlusion. And when you do your try-in, you just got a few adjustments in the front, flat surfaces to get your vertical and your anterior guidance. You got nothing to adjust in the back. I just tried in a case, what's today? I flew yesterday, so on Wednesday, I did all of these procedures. I gave her 4 hours. It took me 2 hours. No adjustment. Or if you do, just a little lop it off. And now I'm going to try all this in. make sure, I got contacts. And then I decide, well, geez, there might have been some little error, maybe some tooth movement, maybe some open contacts. Doesn't matter. We're going to make our problems small. Every appointment is a baby step. So you can only have baby problems. So now we go ahead and try this all in. And you can see I kind of stuck it together here for stability. And I'm checking the occlusion, and I'm taking, do another photo evaluation. And the lower was fine. The upper had some problems. Maybe some open contacts, maybe they were asymmetrical. So I simply lute them together, take another over-impression, and make another model, make these like a transfer case. I guess I did make an upper and lower in here. No, that's actually the same model. I made an upper. Now, any little error, I've got a new model, and I can finish my ceramic. And when I get to my delivery appointment, I got virtually no adjusting. We've already solved almost all the problems. And so the delivery appointment is just one last little baby step. And the problems are minimal. You can spend more time, having fun with your patient. Here's our final case, the smile. Here's a close-up. You can see we still have that gingival recession, which we've got her scheduled to get a graft. Notice on the lower, the illusion is the bright crown. The illusion of length is created by the bright crown. Now, you don't really see this that much when she smiles, but even retracted, these look fairly much the same length, even though we know that there's gingival recession here, because what you really see is the bright crown. You don't see so much the discolored root, in contrast, because we've got a fairly bright restoration here. Check our occlusion, our protrusion, and here's the before. This woman, look at that smile, look at that smile. And they say, it's just photography. But I will tell you over and over again, people that look like that just don't want to smile. They're inhibited. And all of a sudden, you kind of give them teeth where they feel good about themselves. I mean, their whole personality doesn't change, but it can appear to change. And certainly their smile level can change. So don't be fooled by low smile lines either. You think maybe it's not an issue, but you got to trick them into giving you maximum lip extension. So, I'm just about done. Conclusion, while there are many ways to restore defects, the most important thing to remember, I think, go blue. Okay, thank you.